Hello, my name is Kevin Hatton. I'm going to speak about electrolyte abnormalities today. The presentation goals are to describe the cause of the most common electrolyte abnormalities, to describe the clinical manifestations of the most common electrolyte abnormalities, and to describe the treatment of the most common electrolyte abnormalities. First, we'll speak about sodium disorders. In my mind, there are three major take-home points regarding sodium disorders. The first is that the sodium ion concentration is the primary determinant of serum osmolality. Second is that the sodium ion concentration is significantly involved in the homeostatic regulation of extracellular volume. And third, abnormalities in sodium ion concentration primarily affect neuronal and neuromuscular function. First, we'll talk about hypernatremia. In terms of hypernatremia, it is generally indicative of a loss of total body free water with a concomitant intracellular volume depletion. The major causes of hypernatremia include excessive free water loss, reduced free water intake, and excessive sodium intake. This table summarizes these three major causes with the specifics for each of those causes. For example, excessive water loss can occur because of diarrhea, vomiting, sweating, diuresis, or a diagnosis of diabetes insipidus. Reduced water intake may occur because of an altered thirst or, frankly, no access to water. And third, excess sodium intake may occur due to ingestion of salt tablets, the use of hypertonic saline, or the use of sodium bicarbonate. The treatment of hypernatremia generally means increased free water replacement. Free water should be replaced initially at a speed somewhat dependent on the severity of the symptoms. And if hemodynamically unstable, patients should be given normal saline until intravascular volume is corrected. The free water deficit can be calculated using the formula described here, such that the total body water is multiplied by the measured sodium concentration divided by the normal sodium concentration minus 1. So as an example, a 70 kilogram male with a sodium concentration of 160, the calculated total body weight, the total body water is 0.6 times the body weight, so 0.6 times 70, and that's multiplied by the 160, which is the measured sodium concentration, divided by 140, which is a normal concentration, minus 1. So 42 times 1.14 minus 1, or in other words, the total body water deficit, or the free water deficit for this patient is 5.88 liters. The free water replacement should be given in stable patients with chronic hypernatremia, usually through enteral, meaning through the digestive tract, because that's usually sufficient to correct the free water deficit. However, most patients in my experience require parenteral free water with a goal to replace approximately one-half of the free water deficit in the first 24 hours and the remaining of the deficit over the next 48 hours. The sodium concentration should be measured frequently when patients are receiving parenteral free water, and therapy should be continuously adjusted and readjusted for optimal correction of the sodium. The goal for acute hypernatremia is to correct the sodium less than 1 millimole per liter per hour, and in chronic hypernatremia, the sodium should be corrected more slowly, something less than 0.5 millimoles per liter per hour. Overly rapid correction may result in cerebral edema and neurologic injury. The choice of parenteral IV solution should also be made based on an understanding of the necessary balance between the free water and the total body fluid to be corrected, such that each solution that's available has a different sodium concentration, and so the amount of free water is different for each of them. In D5W, there is no sodium concentration, so it is 100% free water. Quarter normal saline has a sodium of 34, one-half normal saline of 77, and normal saline of 154. Clearly, if you use D5W, you're going to replace free water much more quickly than if you were to use half normal saline or even normal saline. So to predict the effect of 1 liter of an IV solution, you want to use the formula described there, where you have the infusate sodium concentration minus the serum concentration divided by the total body water plus 1. So using our example of a 70 kilogram male with a sodium concentration of 160, if we decide to use D5W as our correction fluid, we would have to use 0 minus 160 divided by 42 plus 1, because 42 is the total body water for this patient. And that would give us an amount of 3.72 millimoles per liter. So in that regard, we should assume that for every liter of D5W that is given, we're going to decrease the serum sodium concentration by approximately 3.72 millimoles per liter. Therefore, in order to stay less than our 1 millimole per liter per hour target reduction rate, we should give D5W at a rate no greater than 250 mLs per hour. The total water replacement, therefore, can be sort of summarized in this table, where I've given D5W, or the IV solution, the sodium concentration in that infusate solution, the effect of 1 liter, and then the calculated number of liters of IV fluid that would be needed to correct the total sodium concentration back to normal. Please realize, of course, that changes in sodium will also be dependent on the serum sodium and the overall body weight of the patient. Hyponatremia. Hyponatremia generally indicates an increase in intravascular total body free water with a concomitant intracellular free water excess. The causes of hyponatremia can be classified by the measured serum osmolality, such that you have a hypoosmolar hyponatremia, a normosmolar hyponatremia, or a hyperosmolar hyponatremia. Hypoosmolar hyponatremia is classified based on the evaluation of the patient's total body water balance. So a patient who is euvolemic is likely to have either SIADH, psychogenic polydipsia, hypothyroidism, or cerebral salt wasting. A patient who is hypovolemic, this typically occurs because of thiazide diuretics, aldosterone deficiency, renal tubular dysfunction, vomiting, diarrhea, or third space fluid losses. And then a patient who is hypervolemic is typically due to congestive heart failure, cirrhosis, or nephrosis. Normosmolar hyponatremia typically occurs due to the presence of non-sodium serum solutes, such as either glucose or mannitol. And hyperosmolar hyponatremia typically occurs due to the presence of either hyperlipidemia, hyperproteinemia, or hyperglycemia. The clinical manifestations of hyponatremia typically involve the CNS and the neuromuscular systems, including nausea, vomiting, disorientation and decreased mentation, lethargy, seizures, and even coma. The treatment of hyponatremia is dependent on the underlying disease process and the severity of the associated symptoms. Hypovolemic hyponatremia generally responds to intravascular volume repletion with normal saline. Euvolemic hyponatremia is almost always SIADH and therefore can be diagnosed by urine osmolality. The treatment for SIADH and most other forms of euvolemic hyponatremia are free water restriction, typically to less than 1 liter per day, increasing free water excretion with a loop diuretic, and increasing sodium administration either through enteral salt tablets or parenteral IV solutions. When giving parenteral sodium replacement, recognize that if symptoms are severe or life-threatening, in that regard, rapid correction of sodium may be necessary. Saline IV fluids have varying concentrations of sodium. So for example, normal saline, or 0.9% salt, equals 154 milliequivalents per liter of sodium. Hypertonic saline, which we typically describe as 3% sodium chloride, it calculates to 513 milliequivalents per liter of sodium. So if we use a 70 kilogram male again, this time with a sodium of 120, and we'd like to replace his sodium using parenteral IV fluid to correct an acute hyponatremia, we could use either 0.9% or normal saline with a sodium of 154, Each liter is going to provide approximately 0.8 increase in his sodium, so therefore we would need to give 25 liters of IV fluid to correct his sodium. If we were to use 1.5% sodium chloride, which has a sodium concentration of 257, we'd need to give each liter of IV fluid increases the sodium concentration by 3.2 millimoles per liter, and the number of liters would therefore be 6.3. If we were to correct this patient's sodium with 3% sodium chloride, which has a sodium concentration of 513, each liter would increase by his sodium by 9.1 millimoles per liter, and therefore we would need only 2 liters of 3% sodium to increase his sodium from 120 back to 140. Please recognize that this calculation, as is true with calculations for hypernatremia, do not consider ongoing losses or gains of either free water or sodium. Also, as is true with hypernatremia, changes in the sodium concentration will be dependent on the ongoing changes in serum sodium as well as body weight. Overly rapid correction of hyponatremia can also be dangerous and may result in permanent CNS injury. Most commonly, we describe something called central pontine myelinolysis, which is an osmotic demyelinating syndrome. Frequent sodium analysis is required whenever parenteral hypertonic saline is administered, and in the acute setting you would like the sodium to increase no more than 12 milliequivalents per liter per day, and in the chronic setting no more than 8 milliequivalents per liter per day. We'll switch to potassium disorders next. Potassium is primarily an intracellular ion that is essential for the maintenance of normal electrical membrane potential. Only about 2% of the body's total potassium concentration is found in the extracellular compartments, and potassium disorders primarily affect the cardiovascular, neuromuscular, and GI systems. Hyperkalemia. Hyperkalemia in critically ill patients typically results from renal dysfunction. Other common causes include hypoaldosteronism, cell death from either rhabdomyolysis or tumor lysis syndrome, acidemia, or drugs, specifically spironolactone ACE inhibitors and NSAIDs. The clinical manifestations relate primarily to cardiac and skeletal muscles. Arrhythmias are common, as well as heart block, decreased cardiac conduction and contraction, as well as muscle weakness, hypoactive reflexes, and paralysis. There's a very common EKG manifestation that occurs with hyperkalemia, typically described as either mild, moderate, or severe. In mild hyperkalemia, you typically would see peaked T waves and a prolongation of the PR interval. With moderate hyperkalemia, you would have loss of P waves and a prolonged an increase of the QRS interval. And in severe hyperkalemia, you may see the classic sine wave, which may then eventually degrade into ventricular fibrillation and even asystole. This is a common EKG for very severe hyperkalemia. You can see that in this pattern there are no P waves, the QRS is very wide, and the T wave is also very peaked. Hyperkalemia is treated in several ways. First, if there are significant EKG changes, administer 10 to 20 cc's of calcium chloride over 10 minutes to stabilize the myocardial membrane. Remember that calcium chloride does not change the potassium concentration for the patient, it just stabilizes the myocardial membrane. As you do that, please also institute emergent therapies to redistribute or remove potassium from the body. If, however, your patient with hyperkalemia does not have significant EKG changes, there's really no need to give calcium chloride. You can monitor closely and initiate therapies as appropriate. First, we'll talk about redistribution therapies. In general, redistribution therapies are able to reduce serum potassium concentrations by approximately 0.5 to 1 milliequivalent per liter over a relatively short duration, 30 to 60 minutes. These include the use of insulin, inhaled beta agonists, and sodium bicarbonate. When you use insulin, please remember that you must also give glucose to prevent severe symptomatic hypoglycemia. In the setting of hyperkalemia, typically 10 units of insulin are administered and a 50-gram bolus of 50% dextrose is administered. Inhaled beta agonists like albuterol are also frequently used, as well as the use of sodium bicarbonate. Please remember that sodium bicarbonate is used to correct acidosis, and it may lead to hypernatremia, particularly if repeated doses are used. Removal treatments are able to reduce greater amounts of serum potassium, but may take significantly longer. These include the use of loop diuretics, sodium polystyrene sulfonate, commonly called Kayexalate, and dialysis. If you administer loop diuretics or other diuretic therapy, you may want to continue to give isotonic fluids to prevent the patient from developing hypovolemia. In hypokalemia, hypokalemia occurs from renal or extrarenal losses, from transcellular shifts, and from a decreased intake of potassium. Hypokalemia results in abdominal cramps, nausea, vomiting, arrhythmias, EKG changes, muscle weakness, and paralysis. EKG changes typically seen include U waves and QT prolongation. Hypokalemia is primarily treated based on sodium or potassium concentrations. However, it's difficult to predict how much the potassium will change based on the amount of potassium that's administered. Hypomagnesemia must also be corrected because the two, hypokalemia and hypomagnesemia, go hand in hand, and it's difficult to correct one while not simultaneously correcting the other. And if acidosis is present, you're going to want to correct the potassium concentration before correcting the acidosis. In calcium disorders, the effective serum calcium concentration is best determined by the ionized calcium concentration. The serum calcium is approximately 40% bound to albumin, so that when using the total calcium measurements, they must be corrected for the serum albumin level, which is typically described as for every change in albumin by 1 gram per deciliter, you would expect the total calcium to change in the same direction by approximately 0.8 milligrams per deciliter. Hypercalcemia is clinically manifested through either the cardiovascular system or the neuromuscular system. In terms of the cardiovascular system, you can have hypertension, cardiac ischemia, arrhythmias, conduction abnormalities, and sudden death. In terms of the neuromuscular system, you can have decreased mentation, seizures, or coma. Causes of hypercalcemia include hyperparathyroidism, thyrotoxicosis, excess intake of vitamin A or vitamin D, granulomatous disease, malignancy, and immobilization. The treatment for hypercalcemia includes controlling the underlying disease, rehydration to restore intravascular volume. Typically, normal saline is used because it has no calcium in it. Forced diuresis is frequently used as well, typically with a loop diuretic, and it's typically only instituted after appropriate rehydration, and normal saline is used to replace ongoing urine output fluid loss to prevent dehydration, and then finally dialysis can also be used. For hypocalcemia, the clinical manifestations include the cardiovascular system and the neuromuscular system again. Cardiovascular system abnormalities can include hypotension, bradycardia, QT prolongation, heart failure, and cardiac arrest. Neuromuscular system abnormalities can include weakness, muscle spasms, laryngospasm, hyperreflexia, tetany, and seizures. Causes of hypocalcemia include hypoparathyroidism, massive transfusion, pancreatitis, rhabdomyolysis, burns, sepsis, liver or kidney disease. Hypocalcemia is treated by using first control of the underlying disease. Second, if the patient has mild symptoms only, the patient is typically given enteral calcium. If the patient has severe symptoms, typically the calcium is replaced parenterally, usually either through 10 cc's of a 10% calcium chloride bolus or as an infusion of IV calcium, typically at between 0.3 and 2.0 milligrams per kilogram per hour, recognizing that 1 milliliter of calcium chloride equals 27.2 milligrams of calcium, or that 1 milliliter of calcium gluconate equals roughly a third of that at 9.0 milligrams of calcium. In addition, most patients will require ongoing vitamin D supplementation while receiving calcium replacement therapy. Phosphorus. Hypophosphatemia typically occurs either because of transcellular shifts, renal losses, GI losses, or decreased intake. This chart demonstrates the major reasons for each one of those types of hypophosphatemia. The clinical manifestations include muscle weakness, respiratory failure, paresthesias, lethargy, disorientation, coma, and seizures. And typically patients may also have impaired renal tubular function, impaired vasopressor responses, hepatic dysfunction, immune dysfunction, hemolysis, and impaired platelet function. The treatment for hypophosphatemia is to control the underlying disease, and if mild, symptoms to replace with the enteral phosphorus replacement. If the patient has severe symptoms, typically the phosphorus is replaced parenterally. Potassium phosphate and sodium phosphate are both approximately 93 milligrams of phosphorus for every ml. Frequent reevaluation of serum phosphorus levels is recommended during phosphorus replacement. Magnesium. Hypomagnesemia is typically due to transcellular shifts, renal losses, GI losses, or decreased intake. This table demonstrates or describes the most common causes of each of those types of hypomagnesemia. The clinical manifestations are similar to those of hypokalemia and hypocalcemia, include cardiovascular, neuromuscular, and electrolyte abnormalities. Similar to other electrolyte abnormalities, the treatment for hypomagnesemia is first to control the underlying disease, and if mild symptoms, to give enteral magnesium. If the symptoms are severe, parenteral magnesium sulfate is typically given. 1 to 2 milligrams of magnesium sulfate every 4 to 6 hours is generally recommended, and frequent reevaluation of serum magnesium levels to ensure the patient doesn't develop hypermagnesemia is always recommended. So in conclusion, electrolyte abnormalities are common. Electrolyte abnormalities are frequently due to coexisting disease processes, and electrolyte abnormalities may cause severe complications if not aggressively treated. Thank you very much. I'm Kevin Hatton. Please email me if you have any questions or concerns about this presentation or any questions about critical care at any time. Thank you very much.